Recording on this computer. Okay, I'm Dr. Halasa. I'm the founder of Chronic Disease Prevention and Management Centers. And I'm hoping that we will be creating a full model in Florida for CDPM. And that's why I'm traveling on Wednesday in Florida to meet with the team of doctors who are interested in adapting CDPM as an education platform and also in adapting all the protocols related to chronic disease prevention and management. And as I said, the CDPM is a new field of medicine. It's a new medical specialty that's been entertained by American Medical Association. And they came up with a program to redefine the history and physical exam. It's called the 360 HP. But we are doing even more than just redefining the history and exam to include all the aggravating factor and contributing factors of that trigger chronic diseases. But also we also redefine the therapeutic and the diagnostic protocols to prevent and manage chronic diseases based on the 4 pillars: restoring and modulating the redox, immune, metabolic, and regenerative status of the patients. And this new field of medicine, it can be an opportunity for all the doctors here to possibly get the fellowship program. But we are working on getting the board specialty as well. And you would have the ability to, after taking this fellowship or following us here in our webinars every weekly, you would have the ability and the skills to manage multisystemic diseases, because we know that the specialists did fail in managing post-COVID and COVID-19 because it's a multisystemic diseases. And what we are learning from when we become a specialist, we are focusing on one system. And so if you're a neurologist, you only can manage anything related to the nervous system. And you're not allowed to manage anything outside the system. And that's really, it's not going to work, because if you have leaky gut, if you have toxins, if you have rheumatoid arthritis, if you have metabolic syndrome, then anything that you do to manage any condition that is neurologic, it can be aggravated and triggered by these conditions. So it's better if we able to get the doctors the skill that they need to manage those diseases as a multisystemic, and have the skills and knowledge of screening all these free radical generators, balancing the immune system, looking for any metabolic deficiency, and detoxing the body. And then after that, you can add regenerative medicine after you worked on those 3 pillars, the basic one, redox, immune, and metabolic. Then you can say, I'm going to do some stem cells or exosomes. So this is basically the theme or the concept of chronic disease prevention management. And I think Dr. Joseph James come up with a very interesting molecule. It's called Amlexanox. And this molecule has the effect of steroids without side effect of steroids. That's what it is. Basically, it helps to decrease all kind of inflammation, whether it's Th1 or Th2 or Th3, Th17 mediated. It helps to shift the immune effectors into the Tregs, and without compromising the immune system to defend itself against cancer or infection. So steroids does compromise the immune system, suppress the immune system. This kind of damping or modulating the immune system more than suppressing. And the steroid, what it does, and the problem what it does with chronic use, it inhibits the enzyme is called AMPK. And this enzyme, if it's being inhibited, then what would happen? All the signals that's coming from AMPK which is stimulating the mitochondrial biogenesis and stimulate the activity of the mitochondria and restore the mitochondrial homeostasis, along with stimulating the autophagy through inhibition of mTOR. I know the doctors of A4M, they like to talk about mTOR, although mTOR is not, it's actually not the main thing in the biochemistry. It's not, it's in the downstream. The upstream is AMPK. So AMPK is more important than mTOR. And also AMPK, when it's being stimulated, it will stimulate the NFR, which is the genes that express antioxidants and nitroxide synthase. So by activating AMPK, you can definitely help to restore the mitochondrial function, express antioxidant, increase the nitroxide bioavailability, and you help to decrease the inflammation by doing that. Steroids inhibit the AMPK. And when you inhibit the AMPK, that means you're causing mitochondrial dysfunction, you're inhibiting the expression of antioxidant, you're inhibiting the expression of nitric oxide, the healthy ones, and you will end up with oxidative stress, right? That's the problem. So yeah, the beginning and acute, when you give the steroids, it does help to decrease the inflammation, but with chronic use, it leads to oxidative stress. So that's the problem with steroids. Amlexanox does the same like steroids by inhibiting the LOX and inhibiting the NF-κB, which is the NF-kappa B, that gene or enzyme that express the pro-oxidants, and it doesn't inhibit that. Doing that, you inhibit all the cytokines profile, all the cytokines that leads to polarization of the immune system to Th1 or Th2 and Th17. So it's putting inflammation down, but at the same time, Amlexanox stimulate the AMPK, while steroids inhibit it. When you stimulate the AMPK, that means you can manage the metabolic syndrome, right? Because AMPK is responsible for stimulating the increase in insulin sensitivity, the glucose uptake. It's responsible for increasing the lipolysis, beta oxidation of the fat, and breaking down the fat, and leads to weight loss and getting rid from the hyperglycemia or the cholesterol that's in the blood. So it does help in managing metabolic syndrome, while steroids, it does cause metabolic syndrome. And so AMPK, and it's a very important enzyme that needs to be activated. And we activate the AMPK by exercising. Exercising generate a burst of free radical that will physiological that will lead to activation of the AMPK. And what else? Fasting leads to activation of AMPK. So it's a very important enzyme that we're going to talk about. And we know that aging, why we age, because we know there's two kinds of enzymes, the NFR, which is responsible to express antioxidant, and NF-κB, which is responsible to express the pro-oxidant, right? So we have the antioxidant enzyme and pro-oxidant enzyme. And with age, what happened when we are young, and the antioxidant expression is almost equivalent or equal to the pro-oxidant. So there's a balance there. But we will grow with age. What will happen? There will be imbalance. There will be decrease in expression of antioxidant enzyme and more of pro-oxidant enzyme. And that leads to more of free radicals, pathological one that leads to rusting. And that's why aging is basically rusting, right? And it's due to the imbalance between the pro-oxidant and antioxidant enzyme. So it's good if we can suppress the NF-κB, which is responsible to express the pro-oxidant, and increase the antioxidant enzyme expression. And that's what we can do with Amlexanox. So we can help to balance. So it's a good anti-aging drug at the same time. So it's anti-inflammatory, it's antioxidant, and it's an anti-aging, and also it's anti-cancer. And we're going to learn that it's anti-cancer by many ways. One of them is by stimulating AMPK, which leads to inhibition of mTOR, and this will lead to autophagy of senescent cells, cancer cells, and inflammasomes. So you can get rid from cancer. In addition to that, Amlexanox has a very unique thing that other molecules that we learned before, which is oxytocin, methylene blue, NAC, all those ones that we talked about, we find out that it has a unique thing in regaining the expression of nonsense mutation or nonsense mutant genes. I think Dr. Joseph James talked about it briefly. And give you an example, cystic fibrosis is a lung disease, and nobody can touch it except, we can read the symptomatic um, factors or pathology of cystic fibrosis, right? By what is the treatment that we have? It's just more of tapping, respiratory physiotherapy, giving them antibiotic mucolytics, but nothing has been done in restoring the gene expression of the mutant genes, nonsense genes that express the chloride channels. So cystic fibrosis is a deficiency or mutation of the gene that express the chloride channel, which is responsible to reabsorb the chloride back and dilute the sweat. So because of that, there is no chloride. You end up with thick sweat because it's very salty. And you end up with all this mucus glands secreting thick secretion that blocks all the ducts, whether it's in the respiratory tract or blocking the ducts of the fallopian tubes, or blocking the ducts um, of the genitalia and leading to infertility, or blocking the ducts of the sweat, right? And the pancreatic ducts, which leads to eventually pancreatitis. And there is really uh, nothing out there that we know can restore the expression of the chloride channel. But the reality is that this drug can, and how is that this mutated genes that leads to cystic fibrosis, it's in the DNA. It has what we call the terminal codons, and those DNA. And those terminal codons, which when I was teaching in a college, um, I was teaching the students there how to memorize the stopping codons. And by using those abbreviation, you are gone, you go away, you are away. You are gone, UAG, you go away, UGA, and you are away, UAA. Those are stopping codon that has no equivalent of amino acids. So once you transcribe an RNA out of those mutated DNA with stop codon, you end up with a messenger RNA that has a stop codon that has no equivalent of amino acids. And there will be an enzyme, it's called NMD, which is nonsense mutated messenger RNA DK. It's an enzyme that's abbreviation is NMD. It's an enzyme that will find those messengers, those letters that's being transcribed from the DNA, from the mutated DNA. And if they see those stop codons, they will take them and just shred them, destroy them, and break them. And so the people with cystic fibrosis, they cannot express those proteins. And if we can block the NMD, then we can allow this expression to happen, right? Those messenger RNA to be translated by the ribosomes into proteins. So what will happen is that blocking an NMDA, we can get those messenger RNA not destroyed. In other words, we can prevent them from being broken or destroyed by the NMD. And then the ribosomes can read those messenger RNA and translate into protein. And that's how we can restore the gene expression of this potassium chloride. And yes, during the ribosome, when the ribosome is reading the messenger RNA, they will find a stop codon, but that can be override, and they will insert any amino acids. And Amlexanox will cause that overriding. It's called the rethrow of the messenger RNA, transcriptional rethrow. And they will rethrow this transcription RNA and translate it into a protein. So this is unique. Throughout my medical school studies, and I think all of you as a medical doctor, you never heard that we can restore mutated genes, right? And this happened to almost 30% of genetic diseases, and also cancers. There's a lot of cancers that caused by nonsense mutation, and we can reverse that. And that's going to be a big session for Amlexanox. Maybe the next time I'm going to prepare it because it's a lot of condensed information. I'm just preparing you for the next session of Amlexanox.
Dr. Halasa,
Yes.
can you translate this in terms of the COVID vaccine and spike protein? What you discussed about cystic fibrosis?
I don't think that there is stop codon or anything like that in the pathology of the spike proteins. Spike protein basically it's activating the mast cells, it activates the platelets, and it blocks the ACE2 and hijack renin-angiotensin system. And all of this leads to polarization of the immune system away from Th1 and leads to Th17 and Th2 mediated hyperinflammation. And because of activation of platelets, you end up with high D dimers and clotting, and you will have inflammations. Yes, that's neutrophilic vasculitis or neutrophilic in nature because it's Th17 mediated. But there is no anything to do with nonsense mutation here in COVID.
But what about its effect on an MF kappa B or mTOR
Well, again, if you end up over activating or you end up over signaling the angiotensin 2 type 1 receptor signaling, and that leads to polarization of Th17, you may end up with hyperinflammation of Th17, and there is an activation of overactivation of NFKB. The angiotensin 2 type 1 receptor the downstream signaling is overactivating NFKB, and it's leading to more of expression of the cytokines that is more of Th17 and polarizing the immune system into Th17. So the macrophage will eat those spike protein, and because of the inhibition of the ACE and overactivation of the angiotensin 2 type 1 receptor signaling, it will polarize the macrophages into M17, and then M17 will secrete all the cytokines, interleukin 6, interleukin 7, leads to polarization to Th17, and that leads to polarization of the white blood cells into neutrophils, and you have too much of neutrophil there. In addition to that, when you block the ACE2, you blocking the breaking down of the bradykinin, so you have too much of bradykinins, which also cause the macrophage to be polarized into M2, and then you end up with too much of Th2. But it's more during COVID, it's more Th17 more, especially if the patient is during COVID, it's more Th17 versus Th2 during COVID acute. But in post-COVID, if the patient has itching, then it's more Th2, but there's some of Th17 as well. So there's either Th17 dominant or Th2 dominant. Post-COVID, it's more of Th2 dominant.
I want to send it to her.
Louis,
she won't take it. She doesn't listen.
Okay, can somebody help me with this? Okay, so yes, but I don't see any relationship right now between what we are talking about. Amlexanox definitely will help manage post-COVID. There's no question about it, because it doesn't have the Th17 and Th2. It has all that inflammatory that is overactive. And have the NFKB, which is overactive during post-COVID. It's also Amlexanox, when they first designed it, it was a mast cell stabilizer. It is a mast cell stabilizer. And that's what Amlexanox in the beginning it was. And then they use it also for the first thing they use it is aphthous ulcer, oral ulcers. And then in Japan, they continue using it, or in other words, they end up with investigating this drug, and they find out it works for all kind of inflammation. It works for metabolic syndrome. And in the United States, it's being discontinued in 2017. But it's not being banned, so that's very important to know. Just they find an alternative to Amlexanox to manage oral ulcers.
So what about the post-COVID vaccination syndrome, where symptoms are many times very similar to the COVID and more of a Th2 type of sensitization?
Right. Right, that's what I'm saying. It's Th2 dominant, and also there's Th17. And the reason, as I said, it's continuation of the mast cell activation syndrome. That's what it is, and it's because of activation of mast cells, and uh, that when you have the spike protein is blocking the ACE2, and you have problem with bradykinin overactive, and there's many mechanisms. Spike also activates the platelets directly, activates the mast cells directly. So it's polarizing the immune system to Th2, but it's dominant Th2, and you end up with mast cells, and there's also lymphocytes as well. I mean neutrophils overactive, and you have this inflammation. But it's basically mast cell activation syndrome, and then if the patient has any underlying diseases, it makes it worse because of triggering the inflammation and the oxidative stress. And the way we manage it, as we said, you can use Benadryl at night, you can use Amlexanox to stabilize it during the day and also decrease the inflammation, and manage all the metabolic syndrome which being disturbed by this COVID. And definitely by decreasing interleukin 6, you can also involve in helping and decreasing the coagulation effect of the spike protein. So Amlexanox will be a treatment, it will be a drug of a choice um, for post-COVID-19. I will recommend that. I think Dr. Joseph is already taking it himself. Um, and the safety, it's very high. I mean,
We are
Amlexanox,
talking about the vaccination injury or vaccination side effect,
yeah, the
which happens.
vaccination injury. Yes, there's spike protein similar to COVID. I mean, but possibly the the spike protein or the spike genes are more stable than even the natural virus. So that's the problem. I see that the harm that's coming from the vaccine is way even more than the one that's coming from the virus itself. And another thing is that the virus, when we get infected with it, you still get better Th1 immunity and memories uh, versus the vaccine, which you don't have much of Th1 memories comparing to the natural infection. And that's why you can get more natural immunity. You get balanced immunity. That's better. Balanced immune response with infection versus imbalance immune response from the vaccine. Why? Because the memories are more of Th2, Th17, not much of Th1. And then when the patient is getting this gene again, they have a hyperinflammation, overactive Th2 and Th17, which leads to activation of the mast cells, and they end up with all the symptoms that you see there: vasculitis, multisystemic vasculitis, and inflammation, fatigue, and rash. And if you take sample from those blood vessels, you will see that they are inflamed, and they're inflamed all over, including the brain and the heart. And if patients has any genetics problems already as a base, then that will trigger the whole condition. So um, that's why some people are, getting sick. Some people are not. There is some genetic components. There's also some of the batches of those spike proteins. Some of them are more harmful than others. Some of them are more stable than others. That's another topic. We're going to talk about it maybe when we talk about post-COVID and all that. So Amlexanox is a small molecule target therapy which has been used in treatment of atopic condition and was previously, but it's not currently available in the United States. So it's not being banned. Very important to know. It's not being banned in the United States. Just they find something better to manage oral ulcer. But the Japanese doctors, they start investigating this drug, and they start using it for asthma because it's a mast cell stabilizer. Plus, it's a bronchodilator. That's a good news. It's a bronchodilator. Works like exactly theophylline. You know, theophylline coming from the tea, that extract from the tea, theophylline. And why? Because it inhibits the phosphodiesterase, allowing the cyclic AMP inside those smooth muscles of the bronchus to relax, and this causes the bronchodilation. We're going to see that in the coming slide. So it's a bronchodilator. You can use inhaler, make out of this. There's nobody, no, we don't have in the United States. It's a good thing to start doing it by the compounding pharmacy. That's why I'm willing to recommend Dr. Mike Beamer to develop inhalers. And also because it has antifibrotic effect, It can be used as antifibrotic drug. So we can use it for glaucoma, corneal scar, liver fibrosis, lung fibrosis, adhesions, scar tissue. So that's another application that I'm entertaining, trying to get the compounding pharmacists doing sterile to work with us with this drug, along with losartan, along with KPV. That's what we are trying to get the sterile compounding pharmacy on the board. I mean, non-sterile we're already covered by Amex Pharmacy, is doing very good. Dr. Mike Bima translating everything into formulations, and he already have the Amlexanox oral, but we still need we want to have the sterile part. And so it's legal, utilized in Japan as a treatment for asthma and as for chronic pulmonary diseases, and characterized by inflammation of lower respiratory tract. So you can use it for COPD, asthma, decreasing all kind of inflammation, Th1, Th2, Th17, and also it's antioxidant. It's a bronchodilator. It's a beautiful drug. It's a mast cell stabilizer. Amlexanox, immune modulator. We don't want to say immune suppressor. Immune modulator effects has been the subject of studies, and it's basically a repurposing drug. It's same like we repurpose ivermectin as an anti-inflammatory. We are repurposing this drug as well with potential therapeutic application. This is the beauty of it. So this distinguishes it from steroids. Steroids is good for inflammation, especially the acute, but cannot use it chronically because it inhibits the AMPK, causing oxidative stress and inflammation. But this is an anti-inflammatory, and it is used to treat metabolic syndrome because it activates the AMPK. That's the beauty. Here's the beauty. And this is the statement that we need to learn. This is the drug that's unique. It's an anti-inflammatory. At the same time, it activates the metabolic, activate the AMPK and manage the metabolic syndrome, which is diabetes, hypertension, obesity, hyperlipidemia. All of this can be managed because of the activation of the AMPK. This is how this Amlexanox look. It looks like steroids, right? And the first application that's been approved by FDA in the United States is Amlexanox, is Lexanox. That's maybe the brand name, and it's used for oral ulcers because of its anti-inflammatory effect. And how it works, it inhibits the NF kappa B, and we know this NF kappa B is responsible for expression of the pro-oxidants enzymes and the expression of the cytokines, interleukin 1, interleukin 16, 17, interleukin 4, all of the cytokines. So they're responsible to polarize the macrophage to M1 or M2 or M17 once it's been active, because the free radical is very important to really activate the expression of the cytokines. And so we can use it to downregulate the immune system, damp the immune system without causing without compromising the immune system against infection and cancer. Versus steroids, it damp or suppress the immune system and cause compromisation of the immune system, which is something that we don't want. And so it's a novel therapy, and we know that it's working for inflammatory conditions. And in Japan, they're being used for managing asthma because it's a bronchodilator, and we explain why. Because it inhibits the phosphodiesterase, which allow the cyclic AMP to cause the bronchodilation. And we will continue will continue to be a value in clinical management, especially preventing and management chronic disease across all medical specialties. So this is I believe the Nobel Prize winner drug for our specialty, our new specialty, which is chronic disease prevention and management. We have almost 10 doctors already trained to become chronic disease prevention management. Dr. Patel is one of them. In fact, she's one of the pioneers. She has 6 books of chronic disease prevention and management, by the way. So we are learning from her a lot, from her protocols, and we're trying to work together, integrating it so we can come up with a protocol that's being validated by all of us here. As you see, Amlexanox, how it's inhibiting the TBK1. They are kinase protein, and how they work, kinase protein, they adding phosphate. And when you add a phosphate, you either activate or inhibit the enzyme. And you see here, it's activating the NFKB, this TBK1, and then the NFKB, once being active, they express the expression of the genes of the pro-oxidant enzymes, and also it enhances the expression of anti-inflammatory cytokines, whether it's interleukin 6 or interleukin 1, will depend on what the macrophage is eating, but it enhances the polarization of the macrophage to M1 or M17 or M2, it depends on what the macrophage, and then that will lead to polarization of the lymphocytes. So it helps to enhance the effector T cells, and even naive response, immune response, so increase the expression of interleukin 1, right? And which will activate the natural killer cells. So Amlexanox, as I said, one of the mechanism, it definitely it inhibits the phosphodiesterase, and inhibiting the phosphodiesterase leads to increased cyclic AMP, and then the cyclic AMP will lead to inhibition of NFKB. Okay, so this cyclic AMP is inhibiting the expression of the cytokine profiles. So that's another mechanism where Amlexanox can work in inhibition of NFKB, is by inhibition of phosphodiesterase. When you inhibit the phosphodiesterase, what will happen? You increase the cyclic AMP. And then the cyclic AMP, it's an anti-inflammatory signal, and they will inhibit the NFKB. And then NFKB, if it's being inhibited, you inhibit the expression of the pro-oxidant and the cytokine profile. But also, it's the same mechanism that will activate the AMPK, the cyclic AMP here, they will activate the AMPK. And when they activate the AMPK, it will increase the lipolysis, the beta oxidation, and breaking down the fat, activating the mitochondria, so turning this white fat into brown fat. So it's good for weight loss. It increases insulin sensitivity, so it will help in managing the metabolic syndrome. And when you decrease the inflammation and you decrease the hyperlipidemia, and you decrease the glucose in the blood, what will happen? You will decrease the atherosclerosis, and you manage the hypertension. So Amlexanox, trade name is Sulfa, a tricyclic amine carboxylic acid, a potential treatment option that was traditionally used in treatment of recurrent aphthous ulcer until it's been discontinued, not banned. Very important, because it's not banned in the United States. It's just discontinued because they find an other option better. But the Japanese doctor are more smarter than the United States. They continue investigating the benefit and the mechanism of action of Amlexanox, and now it's being authorized to be used to treat asthma, allergic nitrites, allergic rhinitis, and conjunctivitis. So I can make nasal drops out of it. We can repurpose it. We can make eye drops to manage conjunctivitis, but also I believe because it's antifibrotic effect, we can use it for corneal scar. We can use it for glaucoma. So Amlexanox has also been shown to treat and reverse progression of the fatty liver disease, right? Because it does stimulate the mitochondria, it does increase sensitivity of insulin, and it does helps to break down the fat, right? Lipolysis in the liver, and breaking down the fat. So definitely helps to decrease the fat contents of the liver. And so I can use it to manage the non-alcoholic fatty liver, but also because it has antifibrotic effect, right? Because if you decrease the interleukin 6 and you decrease all those growth factors, the fibrotic factors, then you can definitely help in managing fibrosis and cirrhosis. So it's not just for managing fatty liver, but also I can use it to manage liver cirrhosis. And again, it's a drug that you can use for managing metabolic syndrome, including the weight loss and hyperlipidemia. I can manage hyperlipidemia, hyperglycemia, diabetes, atherosclerosis, and all kind of inflammation, whether it's Th2 or Th17 or Th1 mediated inflammation, autoimmune diseases, ulcerative colitis, Crohn's disease, multiple sclerosis, name them. I can also use it for neurodegenerative disease as well. So it's a drug that can be used for all kind of inflammation, including the metabolic syndrome. And you see here again how Amlexanox, it's inhibiting the NFK, NF-kappa B, that will inhibit the cytokines, inflammatory cytokines, inhibit the pro-oxidants. And doing that, what will happen? You decrease the free radicals, you decrease the oxidation of the insulin receptors, and also the oxidation of the glucose reuptake carriers. And you increase by doing that, you increase the insulin sensitivity and you increase the glucose reuptake. So this will lead to decrease in the glucose level in the blood. So I can use it. It has a similar effect of hypoglycemic drugs, right? That we are using to manage diabetes by doing that. And also stimulate the lipolysis, so I can break down the fat in the liver and burn them and the mitochondria, because we know it's activating the mitochondria. And so metabolic syndrome, it's caused by, on fatty liver, it's caused by metabolic syndrome, basically, right? When you have metabolic syndrome, you end up with fatty liver, because where those fat will go into the liver, and the liver will start building up the fat inside them, and in a form of by lipogenesis, and you would have this storage of fat, globes of fat there. And the way that we can manage it is just activating the mitochondria, activating the lipolysis in the liver, and the beta oxidation, activating the mitochondria, and let's burn those fat, right? I think that's the way we manage the fatty liver, and the way we manage metabolic syndrome. In addition to increasing sensitivity to the insulin and increasing the glucose uptake, so all of this will help in reversing the metabolic syndrome and reversing the fatty liver. But again, if that progresses into liver cirrhosis, still Amlexanox will help, because it will inhibit the fibrosis. And so among the drug that we can use for fatty liver is Amlexanox here, by decreasing the inflammation and decreasing the cytokine profile, inflammatory cytokines. So that's one of the mechanisms, and also by activating the mitochondria and stimulating the lipolysis and the beta oxidation, and burn those fat. So Amlexanox is a stable compound, as and I think Dr. Mike Beamer is going to work on talking about this drug in terms of pharmacodynamic and pharmacokinetics, because he's very good as a pharmacist. We need his version of this drug, and but it's very stable. It has a shelf life of 3 years, if we store it in -20. But I think for regular use, you don't need to put it in the refrigerator. It has a similar chemical structure of sodium chromoglycate, which is the mast cell stabilizer drug, right? So that's the beginning. When they design it as from some sodium chromoglycate as a mast cell stabilizer, but they end up investigating it, and they find out it has all this good pharmaceutical and pharmacodynamic that can be used to manage inflammatory disease and metabolic disease, and also to manage almost 30% of genetic disease caused by nonsense mutation, and also cancer as well, which we're going to talk about it in the second part of clinical application of Amlexanox. So it's a topical use, has been widely accepted, and its effect contributed to its anti-inflammatory qualities. The successful use of this treatment with favorable safety profile. So it's very safe in atopic disease as an oral agent. It has been established and is currently approved for treatment of asthma in Japan, whether you take it orally or possibly you can inhale it. And because it's a mast cell stabilizer, it's anti-inflammatory, it decreases Th2, right? And it decreases Th17, because in asthma it's Th2 dominant, but there's some Th17 inflammation as well. And it's bronchodilator, and it's a mast cell activation, mast cell stabilizer. So that's a good thing for asthma. So the efficacy and safety profile of Amlexanox was previously evaluated by a number of studies, so it's safe. 6-month toxicology study using dog-determined data dosage of oral Amlexanox, which is with no side effects, is 10 milligram per kg per day. What we are using for human now, I think 50 milligram 3 times a day. But you can go, you know, I think Mike is doing 30 milligram 3 times a day. It was determined later that the dosage of Amlexanox can paste for ulcer will be approximately 12 milligram day of Amlexanox. Furthermore, it was demonstrated that when Amlexanox is demonstrated to rat, see how much the high dose is 300 milligram per kg was safe, with no carcinogenic effect and no significant effect on reproductive activities in the rat. But I don't want to give this to pregnant women because of its inhibition of NMD and expression of those mutated genes. I don't know about its teratogenic effect. So what I will say is that I don't have yet any evidence that it's not teratogenic. But I need you to investigate if it's good for pregnant women. For now, I will say no. Okay, until you docs here, because what we're doing here is just more of discussion of science and validate everything and brainstorming. Okay, and we need to make sure things that can be translated in clinical in a safe way. So things that we're not sure, we go say we're asking you doctors here to verify it and then come up with a lecture or discussion where we can say okay for our group here. Clinical application of Amlexanox, the main contraindication of administration of Amlexanox in any known hypersensitivity to Amlexanox itself, other ingredients found in the formulation. So if there's any side effects that happen, it's just because of allergic reaction, like any other drug. Any other drug there, we have a chance that we can have allergic reaction. And that's what's happened. Case report: 23 years old female who was treated for allergic rhinitis with oral sulfa 25 milligram, described an eruptive skin rash during treatment. So it's allergic reaction. She's just and the positive patch test based on suspected allergic localized skin lesion confirmed. And we don't know really it's because of the Amlexanox itself, because Amlexanox itself is used for allergy, right? And it's a mast cell stabilizer. So it could be the ingredients that comes with it, those inert maybe ingredients, maybe impurity. We don't know. But in case that the patient has allergic reaction, you can just give them Benadryl and discontinue the drug. Or if you're giving it oral, you may give it topical. So based on double-blind randomized placebo-controlled study, 42 obese subjects where there were no serious significant adverse events to 3 times daily oral Amlexanox, which is we use 50 milligram or 40 milligram. In the study, 2 patients among all this have experienced perivascular inflammatory rash. Improved with what they didn't even discontinue. Just they instead of giving it oral, they may give it local. Improved with local treatment, and both have a favorable response to the drug. So you can switch it from oral to topical, and you can treat the rash with Benadryl maybe. Given the recent data that demonstrate that potential for Amlexanox as inhibitor for TANK and TBK, which they are kinases protein, and they are an NFA kappa B inhibitor. We can use it to treat and reduce inflammation, all kind of inflammation, whether it's Th1 or Th2 or Th17. Very important that we know that there's 3 kind of inflammation, not one, and they're different, right? And Th1, Th2, Th17. And I need the doctors to be familiar themselves with this 3 kind of inflammation so you can understand how to modulate the immune system in managing chronic diseases. And this is part of our education program, what makes us a little bit unique from other education programs, that we have a little bit edge over what's going out there in other academies. In a wide range of conditions, as I said, you can manage all kind of inflammation, whether it's Th1 dominant, like rheumatoid arthritis, or Th2 dominant, like allergies, right? Or Th17 dominant, like psoriasis, for example. And in addition to that, this is the beauty, it's different from steroids. Steroids inhibit the NAMPK and causing metabolic syndrome. Amlexanox stimulate the AMPK and manage metabolic syndrome, including the non-alcoholic fatty liver disease and diabetes and atherosclerosis and hyperlipidemia. And so this is the enzyme that's very important that we all of us need to learn about it. And maybe we'll have Dr. Patel or Dr. Joseph James or Dr. Kevin or all those chronic disease prevention doctors can teach us about AMPK, because AMPK mediate the effect of exercise. When you exercise, you cause a burst of free radical and stimulates the AMPK. It mediates the effect of fasting. Fasting also leads to activation of the AMPK. And once the AMPK is being active, and when it happens, when your battery is being used, the ATP, and you have too much of ADP or AMP, what would happen? Those empty batteries of the ADP and AMP, they will activate the AMPK. And these are protein kinase. And it also can be activated by cyclic AMP as well. So when you inhibit the phosphodiesterase, which will inhibit the breaking down of cyclic AMP, the cyclic AMP can activate the AMPK as signaling here. And when you activate the AMPK, you lead to lipolysis, beta oxidation, you lead to activation of mitochondria, and you lead to mitophagy, autophagy, you lead to glucose reuptake, increasing insulin sensitivity, and the breaking down of the sugar, right? So this is a good effect that we're looking for. And it's good when we're managing cancer, because you can lead to mitophagy and autophagy, which helps to kill the cancer. But also it inhibits the mTOR. When you inhibit the mTOR, it leads to mitophagy and autophagy as well. So there's evidence of its role as an anti-inflammatory mediator. It's also, as we said, it's antihistamine it's a mast cell stabilizer. And it inhibits the NF-kappa B, which is the enzyme that stimulate the expression of the cytokine profile, inflammatory cytokines, and stimulate the expression of the pro-oxidant enzymes. Amlexanox inhibit the TBK1, those inhibiting the dendritic cell maturation. You remember when I say the macrophages and the dendritic cells, if they want to mature and polarize to M1 or M2 or M17, they need the NFKB to be expressed, so they can express the cytokines, right? That leads their polarization, either to M1 or M2 or M17. And so you need to have an active TBK1. And not just that, also the activation of the innate immune cell response, which is mediated by natural killer cells, right? Interleukin 1 and all that. You need to have NFK to be expressed to increase the expression of the inflammatory cytokines and cause that immune response. And so if you inhibit it, you inhibit any hyperinflammation caused by innate immune response or acquired immune response, Th1, Th2, or Th17. So furthermore, Amlexanox has been identified to bind to fibroblast growth factor. So this is good, because then if we inhibit the fibroblast growth factors, if you inhibit interleukin 6, if you inhibit the secretion of transforming growth factor beta, then this drug can be what? An anti-fibrotic drug. We know that fibrotic disease is pandemic or epidemic disease. It's the disease of aging. The reason why we age is because we have too much of fibrosis going. And why we have the fibrosis going? Because we have too much of Th17 hyperinflammation. Why we have Th17 hyperinflammation? Possibly part of it is the environment that we're living in. We are living inside a bubble of plastic and petrochemicals, right? Everything that's surrounding us, the furniture, all of this petrochemical thing, man-made chemicals, it's polarizing the immune system away from the Th1 to Th17, and definitely it's activating all this expression of those pro-oxidant enzymes and causing us to rust and age and become sick and having cancer. Because once you polarize the immune system away from Th1, you compromise the immune system to fight the cancer and infection, especially the intracellular infections. And again, fibrosis, it's part of those inflammation. Too much of interleukin 6, transforming growth factor beta, and those fibroblast growth factors can lead to fibrosis. And because you're inhibiting this, then we can say this drug can be a drug of a choice to manage fibrotic disease. So Amlexanox is good for neuroinflammation, so I can use it for managing all kind of neurodegenerative diseases, Parkinson's disease, ALS, multiple sclerosis, Huntington's disease, all of those. I can use it for periodontal diseases because of its anti-inflammatory. Because Amlexanox inhibit Th17 and Th2, it leads to polarization of the immune system, Th1, right, in cancer. So this helps in managing cancer. But again, just by inhibiting the NFK and decreasing the free radical, because cancer lives in environment that's high of free radical versus normal cells. They cannot proliferate in a normal redox potential. The redox potential of cancer is very high. That's why methylene blue sticks into cancer versus the normal cells, because they have too much of free radical. The proliferation division of the cancer depend on having a little bit higher free radical status than the normal cells. And so if you inhibit that, you definitely inhibit the cancer. But you're changing the microenvironment, you're inhibiting the Th2 and Th17 immune polarization. This leads to polarization of the immune system Th1 and makes the cancer cell immune system to kill the cancer. So that's a good beauty, especially if you add Amlexanox as an adjuvant to immunotherapy that polarizes the immune system to Th1, like interferon gamma, thymosin alpha. But here's the thing, more than that, those cancers, some of them is caused by nonsense mutation. And if we can reverse that, that will help to prevent those cancer from becoming cancer from the beginning. And we know that Amlexanox activate the mitochondria, mitophagy, and autophagy. So that's another mechanism of killing cancer. So it has all the different aspects of killing cancer, right? Plus, Amlexanox inhibit the fibrosis, so that's good, right? Because the fibrosis causing squeezing of the blood vessels, preventing the white blood cells from infiltrating the cancer and killing the cancer. So antifibrotic effect of Amlexanox, it's part of the managing of cancer because we're changing the tumor microenvironment to be a hostile environment for the cancer by all means. Okay. Now, Amlexanox can be used to manage arthroma. So a patient with, atherosclerosis, it's not just fat plaques in the blood vessels, but the atheroma and atherosclerosis, it's fibrosis. It's not platelets, it's fibers, not just fibrins, okay, and fat plaques, but it's not just clotting factor and fat plaques and fat and hyperlipidemia. No, it's fibrosis and inflammation. And if Amlexanox has antifibrotic effect, so I can open up the blood vessels, I can loosen up the blood vessels and decrease the atheroma, the fibrosis, and widen up the blood vessels by doing that, right? And we know that Amlexanox inhibits the phosphodiesterase, so it does have some vasodilation effect. It has antifibrotic effect. It inhibits interleukin-6, so it does have some antiplatelets effect. So it's very good for patient with, and we know it's managing metabolic syndrome in general, so decreasing the hyperlipidemia, decreasing the sugar. Sugar are free radical generator that's causing the oxidation, the inflammation, right? And so it can be used for cardiovascular diseases. Anybody has arthroma, I can use Amlexanox. Same like losartan. You remember we say losartan is a good drug for treating atherosclerosis? That's why I like to add or switch people with enalapril, captopril to losartan, to ARB. I like IRB. ARB. I prefer IRB over captopril and enalapril, by the way. And why? Because of its antifibrotic effect. And we talked about, the eye drop of losartan, how we can use it to manage corneal scar, and we can manage glaucoma because of its antifibrotic effect. Amlexanox, we can now develop eye drops to manage corneal scar and glaucoma and any fibrotic disease that's of the eyes or other organs, lung fibrosis, liver cirrhosis. And because of its anti-inflammatory inhibiting Th17, which mediate most of the inflammatory diseases and autoimmune diseases when you have too much of Th17, we can use for rheumatoid arthritis, systemic lupus erythematosus, gout. We can use for gout as well. And again, we're going to talk about it, that this Amlexanox inhibits the NMD, right? The NMD, so it leads to expression of those mutated genes. And so I can use it to manage 30% of genetic diseases caused by nonsense mutation and also cancers. and also neurodegenerative diseases and diabetes. If there is an osteoporosis, I can use to manage osteoporosis as well. Why? Because, we remember we say the macrophages, if you inhibit the NFKB, you inhibit the activation of the macrophages and inhibition of the cytokines, inflammatory cytokines, and the free radicals. Think about that osteoclasts, they are macrophages basically, and they're eating the bone. And if the Amlexanox inhibit the NFKB in the osteoclast, it will inhibit the activity of the osteoclast to eating the bone, and that leads to using this drug to manage osteoporosis, right? In addition, if there's any nonsense mutation in any of those diseases, then I can reverse that. And we're going to talk about that in the second part of Amlexanox. So Amlexanox is, I want to thank Dr. Yusuf James for bringing this drug on the table. It does have the similar effect of a peptide. It's called the KPV, right? Correct me if I'm wrong, which is the melanocyte stimulating hormone peptide. That's the 3 amino acid C terminal of this hormone. Because KPV also inhibit the NFKB. And there's few drugs really inhibit the NFKB, by the way. Amlexanox is one, and KVP is the second. There's maybe another drug, but those are two drugs that we can use here in the United States. Now, why Amlexanox has better effect than KBV? Because Amlexanox doesn't have the NMD, which will help to restore the nonsense mutation, and we can use for 30% of genetic disease and a lot of cancer cells. And also we can use for epilepsy. There's some epilepsy disease that's caused by nonsense mutation, by the way. That's a good thing. So the KVP does not have that, right? But the KVP has something that Amlexanox does not have, which is antibiotic effect or probiotic, the probiotic effect of the KVP, inhibiting fungus infection, bacteria infection, right? So that's antimicrobial effect of. So that's the reason I like to combine Amlexanox and KVP together. So a novel study conducted in 2019 demonstrated Amlexanox, when demonstrated both intranasally. So here's the thing: we can repurpose this drug and do intranasal, right? Which we can manage all the kind of neurodegenerative diseases by doing that. And oral significantly decrease the immune cell response and cell recruitment in the lung. So I can use those for inhalation. If I can put it in the nasal, then I can inhale it as well. And I can use it to manage chronic obstructive pulmonary diseases, asthma, right? Lung fibrosis. While this study is in the mouse, there was significant reduction in markers of allergic inflammation because of this mast cell stabilizer. And so we can use it to manage asthma, and Japan is they are using it for managing asthma. In the United States, we have no clue about this drug. I don't know why, but because it's cheap and there's no money for the big pharma. So I think the big pharma, they want to catch and kill it, maybe. Not now. It's still good for us to use it for the compounding pharmacy, maybe 2 or 3 years. But if you really take the big pharma and they see that you are taking the revenue from them, although this is good for the health of the humans, then they may do the catch and kill program and destroy this thing. Based on a previous study conducted by Makino, those are Japanese, by the way, Amlexanox decreased allergic responses, so it's good for asthma. And it's a mast cell stabilizer, which is one of the first drug choice for managing post-COVID-19, because we know post-COVID-19 is mast cell activation syndrome. And you can use Benadryl for at night. It was observed that by inhibiting cyclic AMP phosphodiesterase, so they inhibit the phosphodiesterase, cyclic AMP. So when you inhibit the phosphodiesterase, what will happen? You prevent the breaking of the cyclic AMP to AMP, and you're lowering the increase of AMP, cyclic AMP. And when you increase the cyclic AMP, it will inhibit the NFKB, right? And activate the AMPK and do all the good stuff. Okay, so this is how the mechanism works, by how it's a mast cell stabilizer. It's by increasing the cyclic AMP, and cyclic AMP, increasing it in the smooth muscles of the bronchus, leads to bronchodilator. And so there's another study, I think they're all Japanese, demonstrated, and their name is Gonzalez, maybe South American, seems like. Hilaroyon, I don't know, Hilaroyon is South American or Japanese. Demonstrate that amloxanox also hold a double function in patient cell lines that have nonsense mutation. This is what the beauty of this drug, that I can use it to manage nonsense mutated genetic diseases. Okay. And again, we as medical doctor, we never hear that there's a drug that helps us to manage nonsense mutated genes like cystic fibrosis, and you recover the chloride channel back to normal, right? You can manage the Duchenne syndrome, and you can restore the cytoskeleton protein of those patients with Duchenne syndrome. We don't have that in our curriculum in medical school residency fellowship. And this drug, it's very unique, uh, and it's been found not only increasing the nonsense containing messenger RNA, but also lead to synthesis of full-length functional protein. So it's inhibiting NMD, but also it causes the ribosome to override the transcriptional. It's called transcriptional read-through. Means that messenger RNA, when they have the stop codon, the ribosome supposed to stop when they get into the stop codon, right? Not translated, because there's no amino acid there equivalent to that stop codon. So they just put any amino acid there. And what stimulate is overriding this read-through is amloxanox. Okay. So amloxanox has been authorized to treat asthma in Japan in 1987. So it's a very old drug. If there is anything problem with it in safety or toxicity or anything like that, we will be hearing about it, and they will be banning it in Japan. And it's administered as an oral tablet. Amloxanox is currently produced in either 25 milligram or 50 milligram in by Japan by Takeda Pharmaceutical Company up to now. Okay, it's not being discontinued in Japan. They continue, but we don't have this drug here. In order to mass produce it, you need to go through the FDA approval for this specific condition. But, and when you're doing compounding pharmacy, as long as this drug has an FDA approval for any clinical application, you can repurpose it. So that's lucky for the compounding pharmacy now. I think they can start producing it. I think me and Dr. Mike Beamer and my group are the one who is put the fire on the Matlam Blue, right? And now all the compounding pharmacy in A4M, they start producing Metlam Blue. In fact, I'm asking a lot of people say, are you on Metlam Blue? Yes, I'm taking my Metlam Blue. So it become a drug of a choice, and it has many clinical applications. Definitely, it's buffering the redox, and something that, and it helps in treating a hard to treat infection. And we know the convalescent plasma that's coming from patient with COVID, in order to sterilize it, they take those bags of serum, right, of COVID antibodies from the convalescent plasma, and they add methylene blue, and they pass the red light to disinfect the blood from any kind of infection, even if it's being passing. They're taking from those patients. They know they have, they're doing lab for them to find out that they have HIV or whatever. But sometimes those lab, you get some false negative, and so you can further making sure those blood are free from any germs from HIV or anything that passed the lab, by using methylene blue, putting in the bag and shine the red light. And that's what the FDA approved this Grifols company to make those convalescent plasma available for. It's a Spain company, available for the US when we have the COVID virus. So humans, we are just 80% of water, right? So we're a bag of water. So if we take methylene blue 2 hours before getting into the red bed, we can definitely help to treat a lot of infections, especially those intracellular infections, hard to treat, including Lyme disease. I think that's one of the management that we are going to do in Florida. Previous study have demonstrated its efficacy in treating asthma, allergic reaction, including allergic rhinitis. The drug treatment based on its inhibition release of histamine. So it's a mast cell stabilizer. It also anti-inflammatory effect and inhibit all kind of inflammation. Th1, Th2, Th17. Neutrophil is Th17 mediated inflammation when you have too much of neutrophils. And it's recommended in Japan to treat allergic rhinitis, but I think we can, as a chronic disease prevention management docs, we can repurpose this drug to manage all kinds of inflammatory disease. And we understand the mechanism here, right? So we're not shooting in the dark. When I say I can use it for ulcerative colitis, Crohn's disease, multiple sclerosis, we know why. In human study conducted by, and then we need to see the point. We need data. So we said we are repurposing this drug for this. We have the mechanism. We know why and how and all that stuff, but we need to report cases, right? And now that's what I need you as a doctor to take this drug and start using it and report cases, whether there's improvement or not, or what's going on, and then monitorize your treatment by checking the cytokine profile, lymphocyte mapping, and see if you can make any change there and before and after. Demonstrate that Amlexanox act as bronchodilator. We know why, because it inhibits the phosphodiesterase. It leads to increased cyclic AMP. Cyclic AMP is a bronchodilator. And so we know aspirin, how the aspirin works. It inhibits I think Dr. Battelle would know it. It inhibits the prostaglandin, I think E. And prostaglandin works by increasing the cyclic AMP. So prostaglandin works, how it's bronchodilate, by increasing the cyclic AMP. And so if you inhibit that, you inhibit the production of the cyclic AMP, so we can definitely reverse the effect of aspirin-inducing asthma, because Amlexanox increases the cyclic AMP and help to reverse the asthmatic, the bronchoconstriction effect of the aspirin. Okay, it's throw the cyclic AMP. Aspirin inhibits the cyclic AMP. Amlexanox increases the cyclic AMP, and cyclic AMP causes the bronchodilator. Okay, so if patients is taking aspirin and they end up with asthmatic attack, we can reverse it with Amlexanox. Okay, but we really can use it for all kinds of asthma, which is not necessary to be aspirin induced. We can use it for allergen induced, environmental induced, weather induced, whatever asthma has a patient, because it's a mast cell activator, it's anti-inflammatory. So for all kind of asthma, not necessarily the aspirin induced ones. So the Japanese, they are using it. We need to be smart like Japanese doctors. Okay, they are foreign doctors. But sometimes the foreign doctors outsmarting the US doctors. We think that we are the smartest here. Yes, we have all the tools and all the resources better than any other country there, relatively. Not necessarily true, absolutely. There's some countries would have their more resources than us, but we can argue that we have the highest universities and research and things like that, yes. That's why they come to us here in the United States and they learn from our university. But it's coming a time where we US doctors, we're going to go and learn in their university. And here's a good example. See, the Japanese here, they're smart enough and they are repurposing Amlexanox to treat asthma. And also they are looking and well, here's the thing. It's not completely true, because we will see in the coming slide that California University is repurposing this drug to manage chronic diseases, and we're going to see that in the coming slide. So yeah, we are, but the process of getting it from research and studying, especially for drug that's been FDA approved, into clinical application, mass produced, who's going to determine that is the big pharma, whether they can patent it and make money or not. So that's the drawback. But the compounding pharmacy can override that and really can serve us and serve the medical community and the patients with repurposed drugs that has no interest for the big pharma. It's often prescribed in addition to controller agents, which are prescribed to control long-term some symptoms of asthma. So you can add other things. You can add albuterol and all these things that we're doing, and we add Amlexanox as an adjuvant here. And so the clinical effect of this drug is improving the asthmatic control extended beyond its antihistaminic. So it's not just a mast cell stabilizer, it's anti-inflammatory, and there's many other things that we talked about. So we know that the TBK1 has also been noted to phosphorylate an insulin receptor. And what will happen when you do that? You will end up with insulin resistance, and we end up with diabetes. So if you inhibit the TBK1, which is the the NFKB, right, then you can increase the insulin sensitivity. Okay, and there's a link between insulin resistance and TBK1, and if we inhibit the TBK1, I can use it to manage diabetes. Furthermore, study conducted by Zoe, I think they're all Japanese name, that we can use the TBK1 inhibition to even manage hyperlipidemia as well, right? Why? Because it does help to stimulate the lipolysis and the breaking down of the fat and turning the white fat cells into brown fat cells by activating the mitochondria. And we know why, right? By activation of the AMPK. AMPK is very important enzyme. When we know it's being inhibited by the TBK1 and by the NF kappa beta. And so if you inhibit NF kappa beta and TBK1, you prevent its inhibition on AMPK, you activate the AMPK, and then when you activate the AMPK, you can manage all the metabolic diseases or metabolic syndromes, right? Why? Because of the increase the mitochondrial biogenesis, activation, increases insulin sensitivity, increasing the lipolysis, getting rid from the fat, turning the white fat cells into brown fat cells, and so forth. And also decreasing the inflammation, right? Because the inflammation and the free radicals and all those inflammatory mediators, it's causing oxidation of the insulin receptors and glucose reuptake transporters and preventing it from working. And so decreasing the inflammation, decreasing the free radicals by activating the AMPK, which express antioxidants and inhibit the inflammatory cytokines, would definitely help to increase the sensitivity of insulin and help to manage diabetes, hyperlipidemia, manage weight gain, right, causing weight loss, and eventually it will manage atherosclerosis and hypertension by doing that. So Amlexanox does stimulate the AMPK and it inhibit the mTOR. And there's a mistake here. mTOR stimulate anti-apoptosis. So it stimulates stem cells, proliferation, differentiation. So mTOR is not bad all the way. Of course, you need to have mTOR. To stimulate the stem cells, you need mTOR. But you don't want mTOR to be active in cancers. You need to inhibit it, right? And so we can argue like NFKB, not NFK, what's the name of the hormone we talked about? The KBP, or the KPV, right? The KBV peptide. The KBV peptide does activate the AMPK, and it does help to inhibit the mTOR, especially in the inflammasome and senescent cells and the cancer cells. But this peptide also stimulates the mTOR in the healthy cells and the stem cells. So that's very important to know. Sometimes those drugs, they don't really work the same way as cancer cells and healthy cells. We will see that in cancer cells, this peptide, which is KVB, does stimulate the AMPK and does inhibit the mTOR and does induce autophagy and mitosis and apoptosis in those cancer cells and inflammasome and senescent cells. But they actually activate the mTOR in the stem cells and the healthy cells. And that's why we use KPV to manage retinitis pigmentosa disease, to rescue those healthy cells from dying. So it does have anti-apoptotic effect by stimulating the mTOR. And so we can see curcumin, it does inhibit the mTOR in the cancer cells, inflammasome, and senescent cells, but it stimulates the mTOR in the senescent cells and healthy cells. So, and the reason, because the cells, cancer cells and healthy cells do respond sometimes differently because of the environment of the cells. And that's something I need to emphasize, that when we use the KPV as eye drop to manage pigmentosa retinitis, and the mechanism is by stimulating mTOR. So I don't want you to be confused here. Again, if you activate the AMPK, you activate the NRF2, right? You activate the NRF2, you activate the antioxidant expression of antioxidants and the nitroxide synthesis, and you end up with detoxing. You end up increasing the glutathione and NO and nitric oxide but also a key AMPK. When you activate it, you increase the mitochondrial function, mitochondrial biogenesis, yes, mitophagy, autophagy. And you increase the production of the ATP by doing that, right? And what stimulates the AMPK? Um, Oxidative stress, especially the physiological oxidative stress, like exercising, fasting. All of this may help in activating the AMPK. Exercising, fasting, cyclic AMP, and we know by inhibiting the phosphodiesterase, you can increase the AMPK activities here. And it's very important to activate the AMPK, right? For us to keep health, just to maintain the health and slow the process of the aging, because you need this expression of the antioxidant enzyme, the NRF versus, and you need to inhibit the NFK, NF kappa B, which is the pro-oxidant, so they can balance that. And that's very important because this will slow the process of the aging. We know the aging is because that you have too much of activities of the NF kappa B over the NRF2. NRF2 is the gene or the enzyme that stimulate the expression of antioxidant enzymes. And NF kappa B is the one with pro-oxidants. And so we need to balance that. So we can use Amlexanox and we can use those drugs that we talked about, the KVP as an anti-aging drug. Losartan can be used also in small dose as an anti-aging drug. And mTOR inhibitors can also be used in anti-aging. And again, I'm talking about inhibiting mTOR in the senescent cells, and the inflammasomes, and the cancer cells. And once you inhibit the senescent cells and inflammasome and cancer cells, especially the inflammasome and senescent cells, when you inhibit them, you inhibit the release of interleukin 6, because the inflammasomes and those, even the fat cells too, those big billy fat cells, they secrete interleukin 6 and causing inflammation and aging and free radicals. So too much of fat is not good, right? It's when you see somebody with a big belly, that's visceral fat is killing him, because they induce inflammation. They release interleukin 6 and free radicals, and they will speed the process of the aging. And with these blockers of mTOR, which is the activators of AMPK, exercising or fasting, and using all those drugs that we talk about. And rifampicin is also a drug. It's an mTOR inhibitor as well. We clear up the inflammasome and senescent cells, and we decrease those inflammatory cytokines, and we shrink the fat, right? And this, when you do that, then this inhibit the stem cells, right? Disinhibit the stem cells, and allowing the stem cells to proliferate and regenerate and restore the regenerative status of the patient. Remember when I say the pillar of managing chronic disease is by restoring the redox and metabolic and immune. So when we do that, and we get rid from the inflammasomes and the senescent cells, then you able to activate the stem cells. And if you want to do extra stem cells by giving the patients stem cells from outside, that's fine. But it's very important to work on those redox and immune and metabolic status. We're using all those things that we talked about, those protocols to optimize the health. This itself would help to restore the regenerative status of the patient. So the inhibitor of the IKKE, well, those are kinase protein, DBK1, which all of them, they inhibit the NF kappa B. They're all kinase. They add phosphate group and inhibit the AMPK eventually. Is a proof concept, and they end up with the randomized double-blind placebo control. I think we talked about the study, and we use it to manage the non-alcoholic fatty liver. We discussed why and how and all that. And not just that, it helps to lower the sugar, which means it will help to lower the hemoglobin A1C. But how much percentage of the patient with obesity, when they did a study of the obesity patients, only 30% respond to Amlexanox. 60 or 70% did not respond favorably. In other words, significantly. But 30% significantly improved. And they find out patients who are responded to Amlexanox and they study their fat cells under they did some analysis of those fat cells from those patients who respond to Amlexanox, and most of the time they have high inflammation in the beginning. So when you have too much of inflammation, those obese of the fat cells from the obese patients, if they have too much of high inflammation, they have high respond, versus if those fat cells from those obese patients does not have too much of inflammation, they have less respond to Amlexanox. So the subject who respond to Amlexanox had higher baseline inflammatory markers in the serum and gene expression profile, which is almost 30%. Among the responders to 50 milligram 3 times a day daily dosing at 12 weeks, which helps in increase insulin sensitivity and helps to improve the inflammatory markers. And what's the percentage? I think 30%. Which is good. Then if that's not working, then you can use the peptide, which is the semaglutide. Yeah, we're going to talk about that too. So you start with Amlexanox, okay? And if it's not working, then you can add semaglutide into your regimen. Giving enormous range of potential effect, Amlexanox should continue to be explored with regard to its immunomodulator effect. That's what we want to do here as clinicians, as doctors. We need to get more cases from you, and possibly once I start having my center, the center that I want to do in Florida, that's why I'm traveling there, and we have the CDPM center, and hopefully we can replicate it and transform other clinics to become CDPM. Then we have multi-centers, and then we can share the same protocols, and with the help of the compounding pharmacy supplying us with those formulations that line up with our protocols. Of course, we're going to use the big pharma too. So don't worry if there's any big pharma here. We use both. We use integrative approach and compounding, and also big pharma. Hopefully the big pharma will not get upset from me. So I'm trying to please them. And we're going to use the title that's being blessed by the AMA, American Medical Association. They like the title of Chronic Disease Prevention and Management, and they are promoting it. So we like that title too. We're going to use it. And we're going to create fellowship and residency, possibly board certificate, with the help of all of you here as doctors. I cannot do it by myself. It has to be a teamwork. A nearly absolute asthma treatment may well hold the promise as a therapeutic agent treatment of metabolic conditions as well. So we use it for asthma, metabolic conditions, obesity, and in managing non-alcoholic fatty liver diseases. But also we can go beyond that, and we can also use it for cirrhosis, liver cirrhosis, lung fibrosis, adhesions, and so, as we know here, the non-alcoholic fatty liver is associated with obesity and afflicts an estimate 2 to 5% of American is associated with cellular inflammatory infiltrating liver fibrosis. And so this may help in even reversing the fibrosis, not just the fatty liver. And I think knowing this drug will help us in managing metabolic syndrome. It's a good thing that we can all start using it. And I want to see the response. And how you see the response using the TF function test, use those inflammatory markers, using hemoglobin 1C, right? And then let us know, use this drug, and then, but do those investigation first. And then after 3 months, and let us know, you also scale your patients, the weight as well, all those vital signs that needs to be measured, those parameters, which is simple thing. Just weight the patient, give them the drug. After 3 months, weight the patient. That's simple. Or the TF function test, right? Or those inflammatory or lab work, the metabolic panels that we know. And this may help Amlexanox and curb the growing obesity epidemic. Do you know the obesity epidemic, how much in the United States because of the fast food and all the toxicity that we have in the junk food and all this poison that we are eating? It's 60%. So if you have a clinic and you say, I'm managing metabolic syndrome and obesity, you have 60%. Yeah, 60, every 10 person, they have 6 of them. And 60% is the same number of chronic diseases. 60% of, and that increased. The number increased after, this is a study before the COVID. So after the COVID, it's more than 60%, maybe 70 to 80% right now, suffering from chronic diseases. What about the 20% that are healthy? Those 20%, you can start working on doing cosmetic procedures for them. We're going to teach you how to do that. You can do all the preventive measurements to keep them healthy, right? Because it's chronic disease prevention and management, not just management. And we can provide you with the modules of the education, the training that we have. I think Dr. Mike Beamer is. I think he did finish the Bible of CDPM. He said, I finished the immune side, the redox side, and the metabolic side. I tell him, metabolic, we're going to give it to Dr. William Bill Clifford. He's the pioneer of metabolic, right? He's very good in 6 hormones and all this innovative things that he does. So, and regenerative, possibly I will invite Dr. Farshan. And then metabolic and immune redox, maybe me, Dr. Joseph. There's Dr. Giovanni. I think he's very good in immune modulation. The director or the scientist of the immune sys, or it's called Cyrex company. Giovanni will be good for immune. And the Nathan Bryan will be good for redox. Well, he's good for nitric oxide. Nitric oxide is part of redox. But I will do good in redox myself because I start with that. Further exploration of Amlexanox on potential reciprocation, reincorporation into the United States. That's what we want to do. It's warranted, so it's something that we recommended. Based on current data, Amlexanox as an anti-inflammatory agent and antihistamine has been previously and successfully used in treatment of asthma in Japan and in atopic conditions, conjunctivitis, allergic rhinitis. The target suppression, modulation, I like to say, of chronic inflammation in type 2 diabetes and obesity and fatty liver and metabolic dysfunction warrant further investigation. That's why I'm asking you for further investigation. And investigation is so simple. I mean, basically just use it for your patients as a repurposed drug. And Mike Beamer, as a pharmacist, he have it, and it's very affordable. I think it's 110, I don't know, something like that. As a pharmacist, he's the one is taking charge for supplying us with all the non-sterile thing. And possibly we're going to get somebody to do the sterile part as well. I'm working with some compounding pharmacy. Hopefully some of them will jump on the board and give us the peptide and the sterile part as well. Giving the data demonstrated the potential for Amlexanox as a TBK1 and IKKE inhibitor. This expand the potential for their targeted immunomodulator. Yes, it's an immunomodulator, right? Because it does help to damp the immune, the cytokines, inflammatory cytokines. And I think the other thing, if we end up doing injectable Amlexanox, which I'm working on, and you start doing IV for it or injecting it, and you want to get it into the target pathology, then I would recommend using platelets nanoparticle, which we have the education program for that. So basically, you take platelets, you take Amlexanox, and of course the sterile one, and then you sonicate it, nanofiltrate extrusion, and then you end up clocking those drugs into platelets membrane that has a receptor that has tendency or target to inflammasome, senescent cells, cancer cells, and infection, bacteria, virus, whatever. So hopefully, once you become CDPM, you will learn. We will teach you how to do the platelets nanoparticle in a clinical status or clinical. There is a big pharma doing it as mass production, but they're adding polymers because they want to stabilize it. They can sell it and have a shelf life. But we can just do it at a clinical setting because we don't need to store it, or we use it immediately. And albumin inside the blood will be enough to be stabilizer and as alternative to polymers. And the less modification that you do, is better, okay? Because you want to do too much of modification there. So it's going to be all natural and minimal modification or minimal manipulation. And you get this drug into the pathology And that's part of the training to become CDPM. You have to have that kind of training. In addition to training for doing, there is people in the room. In addition to the training, okay, in addition to the training that we're going to do for fat transfer, Dr. Joseph James and I, we're gonna work on that. We already have trained doctor doing fat transfer, and when we do the fat transfer, we're not just teaching people how to extract the fat. That's the easy part. Is the art part and the hands-on part of injecting those fat into the face, into the boobs, into the area where the patients want it. And that's where you need to have hands-on. And the best way of doing training for this is not cadaver. Cadaver is bullshit. You need to have doctors training on each other. And I use myself as a guinea pig. And I take advantage of that, and they start putting all the fat in my face, which is a good thing. So when we do the training, we are different from all other academies. We don't just extract the fat and the cadaver, which you don't feel it. But you need to have this hands-on of putting in the face and feeling the pain and how you can minimize get that pain by giving the right dose and all that stuff. And you need to have an artist. And Dr. James Joseph is an artist. And I learned a lot from him as well. So me and him, we team up and we can come up to your clinic and do the training for you. So if you see here the AMPK, how it's very important, right? And fasting is activating the AMPK, exercise activating AMPK, and any drug that increase, that increase the AMPK, AMP, or cyclic AMP will activate the AMPK. And see the good thing about AMPK, you can induce autophagy in the senescent cells, inflammation, and cancer cells. You can stimulate the sensitivity of insulin, increasing the glucose uptake, so you can manage diabetes. You can stimulate the fatty acid oxidation, burn the fat, right? And you can have the mTOR. We know the mTOR what does, right? It stimulates the proliferation and invasion of the cancer. So this is good to be inhibited in the cancer cells or inflammasome or senescent cells. But it's good to be activated and when it comes into healthy cells. That's why when you fast, what you're doing fasting, you're killing inflammasome, senescent cells, and cancer cells. But when you eat and you have the sugar is going up, you stimulate the mTOR so you can activate the stem cells to start growing. So that's the mechanism of fasting. First, kill this inflammasome, senescent cells, and cancer cells, right? And disinhibit the stem cells. And when you eat, your sugar goes up. Then this will reverse the whole thing and increase the mTOR activities and stimulate the stem cells and regenerate, right? So killing, cleaning, and then regenerate. That's the mechanism of we call the fasting. Fasting in the Ramadan, or Dr. Joseph James is talking about the time fasting thing, right? 12 hours fasting, and then allow yourself for 12 hours to eat. And try to eat just, it would be good to just eat one time a day, especially if you already have a genetic inflammatory tendency, like if you have gout or you have psoriasis or anything, then I recommend just one meal a day. Or rheumatoid arthritis, I would recommend all those people to have one meal a day and drink a lot of water, but one meal a day is the best thing for them. And so during the fasting, you start killing all the inflammasome and cancer cells and improving your metabolic profile and lowering the sugar and all that stuff. And then when you eat, you start stimulating the stem cells and all that good stuff to regenerate. And so chronic inflammation across all the medical specialties, across all the board, whether it's cancer, this is what we do as when you become chronic disease prevention management specialist, right? You know, the other term of it is integrative, regenerative, holistic, but all those terminology, there's the bad players there and big pharma and the mainstream, they are stigmatizing these fields. They say, oh, you're not evidence-based and all that. So we're going to use the term that mainstream medicine understand, which is chronic disease prevention management. And it includes all this. Think about it. As CDPM specialist, you can manage autoimmune disease across our medical specialty, cardiovascular, metabolic, bone, manage. We don't say cure. Okay, don't say cure, but say manage, which is better. So then the specialist, if they want to do the cure, you give them to the specialist to do the cure. But use the word manage and prevent all these conditions, including cancer. So yes, even in AMA, they have chronic disease prevention (CDPM) is also managing cancer. So when you become a specialist, you have the authority to manage and prevent cancer, but not cure cancer. Don't say cure cancer. Give that word to the oncologist. Okay, they're a specialist. They can use that word, but we don't cure. Okay, we manage. Okay, we prevent and manage. And a lot of doctors say, "Oh, cure doctor patients." I don't want to hear that. They want to hear cure. Well, we don't falsify things, and we don't give false promise. That's very important. Metformin, how it works by activating the AMPK. So that's why metformin, uh, the doctors of A4M, they entertain it and they like it. The problem with metformin, yes, it does help to stimulate the AMPK, but in certain way it interferes with the mitochondria. So with long-term use of metformin, if you interfere with the mitochondrial function, you lead to oxidative stress. But that's not good. Unless you add the QQ10, possibly that will help to reverse that. The same like statin. Statin doesn't stimulate MPK, but it does interfere with the mitochondria. So that's the problem with the synthetic drugs. Versus when you use polyphenols, curcumin, ECGC, quercetin, resveratrol, they all stimulate the MPK without that interfering with the mitochondrial function. Again, as you said here, that when you block the NFK kappa B, you decrease activity of the macrophages and also the osteoclast, right? All the cytokines will be decreased and you inactivate the osteoclast. What will happen when you do that? You decrease all interleukin 6 and all that stuff, and you decrease activity of osteoclast. You can use this drug to manage osteoporosis, right? Again, this is just shows you how all this inflammation, how the macrophages, when they are receiving infection, lipopolysaccharides, or aging, all this, insults, and how this insults of injuries, whether it's clinical or biological, and how this macrophages will lead to activation into an IKK, which is NF kappa B, and NF kappa B will lead to expression of the cytokine profile. It depends. If it's bacteria, then the macrophage will polarize into M17. If it's allergens, then the macrophage will polarize to M2. Um, if it's cancer, then the macrophage will polarize to M1, and then that will lead to polarization of the immune system. But if you have too much inflammation, like in case of you have COVID, and you have too much of macrophages, because the spike protein is fooling the macrophages, even the polarization, and they think they are bacteria, not viruses. They polarize into M17 and Th17. You have hyperinflammation. It's all because of overactivation of NFKB, and that's why we can use this drug to manage COVID and also post-COVID. Again, cancer cells, they are activating the TBK1. Why? Because the TBK1 helps to increase the free radicals, and the free radicals, pathological, is very important for the cancer to proliferate and differentiate. But also activating of TBK and releasing the cytokines that polarize the immune system away from Th1, which polarize the immune system to Th2 and Th17, will make the microenvironment in favor of the cancer grow. This inflammation that is Th17 and Th2, what you can get from it? Neutrophils, mast cells. Those neutrophils cannot kill the cancer. You need Th1, you need cytotoxic T cells. But the tumor is very smart. They hijack the immune system and they modulate them and move them to Th2 or Th17 or possibly Tregs. And this will suppress the Th1 and cytotoxic T cells of killing the cancer. And so if I can reset that by inhibiting the whole kind of inflammation, hopefully the Th17 and more of the Th17 and Th2, and then I add to the cocktail photosensitizers, low dose chemotherapy, immunotherapy, especially interferon gamma, and polarize the immune system to Th1, I can definitely manage the cancer better. So this just shows you that overactivation of TBK1 can compromise the immune killing of the cancer, especially those tumor. They secrete other chemicals that leads to polarization of the immune system into M17 and M2, and that leads to inflammation that cannot kill the cancer, which is neutrophils and mast cells and basophils and antibodies. All right, you need cytotoxic T cells, so you need to polarize the immune system. So you need to inhibit those false or those inflammation that promote cancer growth and invasion and all that stuff. This shows you again how when the macrophages is encountering lipopolysaccharides from a bacteria, which macrophages, they use toll-like receptors like tongues, and they sense things outside, whether it's lipopolysaccharide or virus or cancer cells, and through that it will signal the macrophage to which direction they will polarize. In this case, if it's bacteria, they will polarize into M17 because they will secrete interleukin 6. And that interleukin 6 will polarize the macrophage to M17, and M17 will polarize the naive T cells to Th17, and that will produce neutrophils, and neutrophils will kill the bacteria, right? Because that's how we kill bacteria, by neutrophils. So it's a good thing. It just shows you the mechanism of how this toll-like receptors, when they taste the lipopolysaccharide from the bacteria, they activate the NFKB to stimulate the expression of the interleukin 6 to polarize the macrophage into M17, and M17 secreting interleukin 6 will lead to polarization of the naive T cells to Th17, which secretes interleukin 7. And interleukin 7, along with transforming growth factor, along with interleukin 6, will polarize the immune system into the white blood cells into neutrophils, and you will have also some fibrosis as well going on. And so if we block the TBK1, we can decrease the inflammation, right? Okay. What else? Again and again, when we start having, if you try to target your injectable drugs, whether it's cancer drugs or anti-inflammatory drugs, so Amlexanox or KVP or peptides, or immunotherapy antibodies, which is CTLA-4 antibodies or PD-L1 antibodies, anti-cancer antibodies, those ones are immune modulators. It's better if we load them inside platelets nanoparticle, and we can teach you how to do it. Why? Because first, that size of 100 nanometer, they will seep into those pathology that has leaky blood vessels, versus the healthy tissue, because they're tight, they cannot pass through. So you're getting all these drugs into the pathology, those leaky blood vessels of the pathology. And then when they get there, the receptors inside or on the platelets, it's naturally has a tendency to attach to bacteria, virus, microbes, and cancer cells, inflammasomes, senescent cells, injury cells. And that's where you have specific, which is active targeting plus passive targeting, along with the size of the nanoparticles, which favor delivering the drugs into the leaky blood vessels versus the tight blood vessels of the healthy tissue. Again, if you can use stem cells, we can use from fat stem cells, and when we do the fat transfer, and we start breaking it down, micronizing it, you can further take this micronized fat, centrifuge it, and you can get the bottom of the stem cells, right? Because those micronized fat, you break down the stroma, and those stem cells, you can extract them in case you want to do stem cells. In case you want to do fat transfer and just cosmetic, you don't need to separate the stem cells from the whole fat tissue. So during active micronization, which is a thing that we teach, you can take those micronized fat and further centrifuge it in a high centrifuge, and you can get the stem cells at the bottom, and you can use the stem cells to load drugs in their membranes, right? Using the same thing, sonication, filtration, and extrusion. See it here, the extrusion here. You see that? How the extrusion, and we're going to teach you how to do the extrusion. It's passing the drug in the membrane into a filter, a specific filter that we teach you how to do it. And again, you can use stem cells. You load them with cancer drugs. You load them with anti-inflammatory. You load them with antibodies. If you go to a company, it's called Cella Therapeutic, and they're talking about this membrane-loaded nanoparticles from stem cells and from platelets, and they are doing very good job, but it will take them 20, 30 years for them to stabilize them. But they use polymers to stabilize that drug, and there's a problem using polymers. Anything synthetic, you don't want it. So clinically, we can use it without using the polymers. Again, chronic disease prevention management, it's a new medical specialty that focuses on developing diagnostic and therapeutic protocols to manage all kind of chronic disease across all medical specialty by restoring the redox, metabolic, immune, and regenerative status of the patient. I welcome everybody here to be part of this movement, part of the specialty where you can manage better than specialists when it comes into multisystemic diseases like COVID or cancer or all those really chronic disease. They are multisystemic. They're not really. Yeah, you can see how I have a Parkinson is neurological disease, but if you have rheumatoid arthritis, if you have leaky gut, if you have toxins, if you have fungus, all of this can aggravate the Parkinson. So you need to have that ability to think outside the box and manage the multisystemic diseases in a comprehensive way, not in a very tunnel vision way. Because those people who are managing diseases in a tunnel vision and systemic wise, it's like exactly a mechanic when he's trying to fix a tire, and he just patch one hole, and then the three holes are still open. Even if he patch that hole, the tire will not work because the other hole is not being patched. So I think I myself, I was fixing my own tire in overseas, and I take the tire and I put air in it, and then I put it in the water to see all the bubbles, and then I patch the tire. And I think chronic disease is the same thing. It's like fixing a tire that's have many holes. Anyway, any questions? I think we're done. What's the time? How many? 2 hours? Okay. Questions? Did you fall asleep? Well, it's not that much. It's only 9:33. So it's only 1 hour, maybe 7:30. We start 7:30. There's 2 hours. That's not a lot. Any questions?
I had a question about the whether you did indicate on one of the charts lupus would be helped by this. I'm a dentist, so I don't know a lot about that, but how would lupus benefit?
You mean patient with systemic lupus?
Patient with, yes.
Yeah, definitely, because the systemic lupus, it's Th2, Th17 mediated inflammation. And if Amlexanox inhibit those two inflammations, then definitely it will be a replacement of steroids without side effect of steroids. It doesn't, Amlexanox doesn't have the COX and LOX, same like steroids and NFK, but it does not stimulate the AMPK, so it does not cause any oxidative stress or metabolic diseases. So I can use it to wean patients from all those harsh immune suppressive drugs. We start as an adjuvant, and if it can replace it completely, that's good. If not, just reducing the amount of steroids and all those harsh chemicals, it consider a success.
Good, great. I'll pass that word on.
Okay. Any other? Dr. David, how are you? Your voice is not there. You're muted. We'd like to hear your voice. All right. Well, we don't hear your voice, but I will ask you to unmute if you want to talk. Anybody wants to talk? Yeah. Go ahead.
There you go. What's the normal dose?
The oral dose, according to Joseph James and Mike Beamer, he's using 40 milligram 3 times a day.
With food or?
Mike Beamer has it. I think Mike Beamer is carrying this drug.
Is he going to provide us with? Is he going to provide us with an informed consent?
Well, it's a repurposed drug that's FDA approved, like any other drug.
Well, it's being used experimentally, so you should have an informed consent for everybody that takes it.
Right.
You know.
Yeah, it's a repurposed drug. Yes, it's an FDA approved drug. Well, according to Mike Beamer, he said if Mike Beamer can do it, Mike Beamer is very strict in regulations, and like if you ask him to do peptides, he will say no. But why? Because he said the peptides doesn't have the monograph. It's not FDA ingredient. I'm not touching it. But anything that has FDA ingredient and has a monograph, you can repurpose it.
I'm not arguing that. I'm just saying when you're talking to a patient that doesn't know anything about it and they know that it's not FDA approved for this purpose.
Oh yeah, you need to do consent in anything. Yeah, when
that's
you be
the point.
creative in any of those things, you need to have a consent form for any repurposed drug. Yes.
And are there any drug interactions?
According to what I saw, there is none yet. There is allergic. People can be allergic to it, but there's a small percentage. And discontinuing it or changing it from oral to topical, and we learned that from those cases. Like any drug, there is allergic reaction sometimes. You can start
And
with
what,
low dose
what,
and go up.
what kind of allergic reactions?
It's a perivascular inflammation. So basically, it's Th2 inflammation. Maybe
Vascular, what does that mean? Vascular inflammation.
it's
That
it's
could be my
allergic. Like,
coronary arteries. It could be my
well,
middle.
no, very
cerebral
well.
artery.
It's more of allergic reaction, like any allergy, like when you have a atopic allergy or something like that. So it's a Th2 mediated allergic reaction.
Like my COVID vaccine. That was an allergic vascular reaction.
Right, but that's even worse. That's also Th17 as well, not just
Yeah.
Th2. It's neutrophilic inflammation. Right. Any
And
questions? Everybody's happy?
how about alcohol?
I did not see any and yet. If there's anybody here, can investigate more and see if there's any interaction with alcohol. I know I will not give it to pregnant women. That's for sure. Until somebody clears it. For me,
So-
I will recommend against giving it to pregnant women.
Does it interfere with stem cells?
I don't know. There it could be some teratog. I have no clearance for teratogenic effect of it for pregnancy. I don't have study or data for clearing that. Maybe Mike Beamer will, when you reach out to him, he may clarify things.
How much
So
does
I
it
will tell
cost?
you what I know, and what I don't know, I'll tell you I don't know.
What's it cost?
What is that? I think he's making it
What does it
110 for
cost?
90 capsule, which is enough for 1 month, I think, if you're going to use three times a day.
Okay.
Right. But you talk to
So-
him and find out. Anybody else?
Thank you.
Sure, anytime, Dr. Dave. Dr. Patel, are you there? No. Dr. Jusic? Dr. Lewis? Are you
Dr.
all
Halasa?
happy? Any questions?
Hey, Doc.
Yes, go ahead.
This is Jonathan Carlier from Precision Compounding Pharmacy.
Yes.
I sent you an invite. I look forward to our conversation tomorrow if that happens. Listening to some of your concerns about Big Pharma, because I did verify while we were on the call tonight that Amlexanox is available generically in a powder form, so we can compound it. And we'll talk about the sterile applications and ideas for that tomorrow on our call, hopefully. But because there's so many different uses that we talked about this evening, Big Pharma really will try to get a patent for one use. They've already abandoned the drug and discontinued it for the oral ulcers. So all of these other
No, not ban it. There's a difference between ban and discontinue.
they discontinued, right? They
Yes, the
discontinued it for
ban is a
oral
different
ulcers.
word.
They've
Ban, that means they find something wrong in it and they ban it.
Right. They've abandoned it, not banned it. They've abandoned it.
Yeah,
So
yeah,
now
discontinue
it'll
it
be
because of
considered
yes.
now it'll
Yes.
be considered a generic orphan drug, which means as long as it's not been banned by the FDA and it's a abandoned drug and the ingredient is available from the FDA approved wholesalers.
Right.
So we can source the ingredient and get that, so that's not an issue.
Okay. That will be great. We're looking for sterile. I have somebody for non-sterile, so I'm good.
Yeah, we're talking
And
about
Mike Beamer is a very good guy, and Amex Pharmacy are the best in terms of for many years I've been working with them. But I don't have the sterile and I don't have the peptides. You said KPV, you cannot do it?
KPV. We should talk about more in depth.
Okay.
I
It's only
agree.
3 amino acids and
Right. So there's some ways we can do those 3 amino acids without calling it KPV, perhaps.
Okay,
But as you know, you just said a few minutes ago, there's no FDA approved version of KPV.
right.
are-
So that's one
there are
reason
more
I
and
need
more
you to be
peptides.
creative there.
Right. There are more and more peptides that are coming out that are components of FDA approved drugs almost on a monthly basis now. As we've seen with the GLP drugs, and there's more and more drugs that Big Pharma is coming out with that are peptide based drugs.
Right.
So that's good news. That's good news for us that are enthusiasts about peptides.
Well, we need to be more creative, and without the compounding that's your job as compounding pharmacy. You getting all those translated drugs, repurposed drugs, where the big pharma have no nothing in it. In other words, they don't can make big money that they want to make, and then the compounding pharmacy will at least they eat the bones.
Yeah. Yeah. Right.
They will left the bones for you, but sometimes even the bones they will say no, too much for you.
It really depends on the regulations and the rules.
Right, and then they say it's too
They're
much
very,
for the bones,
and they're
and then
very
they do the catch kill thing.
right.
Okay, so
And
now we're going to ban it.
Right. And the rules are varied by states now too.
Right. But hopefully we will keep lining up with the regulations, because that's what we like all the time, and we will respect the U.S. regulations, and that's very important. And if there's anything creative, you can do it outside the United States. We do have a clinics outside as well. And we have something in Bahamas going on, and Dubai is coming as well. I have a center in Dubai. Possibly they're going to join us. And we can do a lot of creative things in Dubai.
Yeah.
And again, safety is very important for all of us. Safety is number one. And if we see anything that interfere with safety, we'll definitely discontinue it, or we will not entertain it. And that's something we need all of us to. That's the reason you're here, to verify things, to criticize things, and so we can make sure that all this information is being vented by the doctors. And that's very important. Any questions? Are you all happy? We'll see you next Monday. Okay, well, good night, everybody.
Okay. Thank
Take
you.
care.